He did this.
Hello? Hello?
Yes, hello, madam.
Yes, good afternoon, team.
Good afternoon.
You're most welcome this afternoon for our echo session. This is the 6th session this year and the 60th session since the program started. You're most welcome. My name is Wembabazi, nursing officer from Kayunga Regional Referral Hospital, Incharge, accident and emergency. I'm going to be the moderator for the day. Before we begin, we are going to begin with a word of prayer from Dr. Jimmy Atyera.
All right, let's pray. Loving Father, I want to thank you for this session that we are going to be having today. We pray that, Lord, you give us wisdom and understanding, and we pray that you help us to conceptualize whatever we are going to discuss for the betterment of service delivery. In Jesus' name I pray. Amen.
Thank you very much, Dr. Jimmy. Our program goes like this. First of all, you know, these sessions, we begin with pre-tests. So they'll load on the test. Those who don't know where to get it from, you go to more, then you go to polls and quizzes. That's where you get the pre-test from. Then we shall have, with questions, others will write in the chat, and then raising of hands. We shall be answering you. In the house, we have different people. We have consultants, we have nurses, doctors, and experts. So with me, I have panelists. Among the panelists, we have experts, we have nurses and doctors. So I'm going to request my team to introduce themselves, starting with Dr. Zelda, who is going to be our case presenter. You introduce yourself, you tell us who you are, where you work from, and your role in this session. Thank you.
Good afternoon, colleagues. I'm Dr. Atumanya, and I work at Kayunga Regional Referral Hospital, and I'm a medical officer at Accident and Emergency, and I'm going to do case presentation today.
Thank you, Dr. Zelda. I'm going to request Dr. Jimmy to introduce himself.
Good afternoon. My name is Jimmy Atyera, and I'm an emergency medicine resident at Makerere University. I'm in my second year, and I'm happy to be part of the panel today.
Thank you. I'm going to ask Cholera to introduce himself.
Thank you, Martha. Good afternoon, colleagues. My name is Cholera Abatineko, medical lab technologist, Kayunga Regional Referral. Thank you.
Thank you. I'm going to ask Sister Babirye Teddy to introduce himself.
Thank you, Madam Moderation. Good afternoon to you all. Good afternoon to you all. I'm Babirye Teddy, critical care nurse, Kayunga Regional Referral Hospital. I'm going to take you through management of a cholera patient, nursing care management.
Thank you, Teddy. I'm going to request Dr. Davis to introduce himself.
Good afternoon to you, dear listeners. My name is Dr. Davis Akankwa Sabakine.
the Incharge Emergency and Accident Unit. And in this session, I'll be responding to the questions posed to the members after the presentation.
Thank you. We have our expert, Dr. Nakalema, will be with us shortly. And we also have the IT, I also welcome the IT group. Thanks very much for the good work that we are doing. Shortly, they will be uploading the pretest. So I'm repeating those who don't know where it is. You go to more, and then you go to polls and quizzes. That's where the questions will be. As you know, it doesn't take long, so you have to be alert and answer quickly. And those who have questions, you can write in the chat and raise your hands. So our experts will be answering those questions. The next, we are going to have a case presentation. And in case you have any query, you have anything you want to know, you raise up your hand or write in the chat. We shall be able to respond to you. I have a very expert team that is helping me up. Thank you. So the pretest is uploaded. You can start. Pretest is running. We have 3 minutes to go. Those who have questions, please write in the chat, raise up your hands. We'll respond to you. We have different experts in the house. We have 1 minute to go for the pretest. We are closing up with a pretest. Please submit. Thank you, team. Our next agenda is case presentation. So I welcome Dr. Zelda to take us through the case presentations. And after every presentation, we shall have few questions and discussion before we go to the next. Thank you. Dr. Zelda, you're welcome to take us through the case presentation. Yeah, we are. Okay.
Once again, you're all welcome. I'll just go straight to the next slide. Presenting MS, a 17-year-old male.
Some technical issues, but we are coming.
I'm presenting MS, a 17-year-old male, brought in from home. Let me just open mine on the phone.
You just present what you do.
Presenting MS, a 17-year-old male, brought in from home, semi-conscious, presented to the emergency department with a 2-day history of diarrhea, vomiting, general body weakness, a 1-day history of cough, and reduced level of consciousness for 6 hours. And our emergency assessment, the airway, patient had no abnormal sounds and had no secretions. His air was patent, however, it was threatened because this patient was semi-conscious. And for breathing, patient was in mild distress, the respiratory rate was 20, SpO2 was 89 to 90 at room air, chest was clear with equal air entry. And the intervention that we did, we administered oxygen therapy 3 liters per minute by nasal plungs, and his SpO2 improved to 95% on oxygen. And saturation, PP was 90 out of 55, pulse rate was 110. It was rapid, thready, but normal rhythm. Sounds S1, S2 were had only with no added sounds but tachycardic. He had cold extremities. His capillary refill was greater than 3 seconds, and he had a slow skin pinch. So our intervention was, we inserted 2 large bore cannulas and resuscitated the patient with IV fluid syringes lactate 4.5 liters, using the 30 milligrams per kg in the first 30 minutes and 70 mils per kg in the next 2.5 hours. And we estimated his weight to be around 45 kilograms. Since he was unconscious, we just had to estimate his weight. And we gave him warm fluids because he already was having cold extremities. Next slide. Disability. Our patient was semi-conscious. His GCS was 11 out of 15. The motor was 5. Patient was localizing pain. Eye opening was 3. It was to pain. And verbal was 3. He had some incomprehensible words. His RBS was 4.1 millimoles per liter. Pupils were normal, were of normal size and equally reactive to light. His neck was soft, Canning and Brudzinski sign were negative. And what the management that we did there, we positioned the patient in recovery position, and we had to put the NG tube and insert a catheter, and we gave D50 30 ml start, because our RBS is not really a hypoglycemic one, but since this patient had been vomiting and not feeding, we had to give some glucose such that we don't go into hypoglycemia. On exposure of this patient was already cold with cold extremities, and we couldn't really take the temperature at the moment, but he was cold and he had no life-threatening injuries on examination. And to keep him warm, we just covered him up and continued our warm fluids. Next slide. Our signs and symptoms of this patient. This patient, we got collateral history from him. So attendants reported he had had several episodes of profuse diarrhea, approximated to around 15 episodes in a day, non-bloody, no associated abdominal pain, and he had had about episodes of vomiting, and he was just vomiting fits. The cough was also non-productive. No more history could be taken of the cough, since the patient could not really explain to us himself. And the history of reduced GCS was 6 hours like prior to admission. And I noted that neither fevers nor convulsions were reported by the attendants. He had no history of any drug allergies or food allergies. And before they came to the hospital, they had tried to manage their patient with some oral hydration salts and antiemetics, and that was metoclopramide. And the patient was not, he had no other history of any chronic medications. The patient also had no history of illnesses.
Okay.
Next slide. And the past medical history, it was the index admission with no known chronic illnesses. And it was really an social history. The patient was not married, did not smoke, not drink alcohol, and he was a firstborn of 4. He had had the last meal 7 hours back. However, patient had been vomiting every attempt to give him feeds. And in the index, we noted that patient was just found in his bed with a reduced Glasgow scale around 6 hours prior to his admission. No history of any trauma was mentioned by the attendants. Next slide, please. That should be my problem list. And the first one was severe dehydration in this patient, hypotension, reduced level of consciousness, and feeding difficulties. Next slide, please. So amongst our investigations, some we had done, they included RBS, which was 4.1, CBC had normal parameters, MRDT was negative, we did a Cholera RDT, which was positive, and serum electrolytes, the potassium was 3.0, which was a little bit low, sodium of 144, and the chloride of 115.7. RFTs, his creatinine was 146, it was slightly high, and his urea was 9.1, it was also slightly high. LFTs were this line normal, and RCT was negative. Next slide. And those are samples of our results. We just noted 2 of them, and we can go to the next slide, please. So our diagnosis, we made a diagnosis of cholera complicated with severe dehydration and hypotension, electrolyte imbalance, and upper respiratory tract infection. Next slide. So we in treatment and follow-up of these patients, we had a definitive treatment, and since we had already had an RDT of cholera positive, we put this patient on IV ciprofloxacin 400 milligrams BD for 5 days, and our supportive management included continuation of oxygen therapy, We gave metoclopramide to try and reduce the vomiting. We maintained him on the D50. And we had to maintain him on IV fluids, and that was Ringer's lactate 500 ml per hour for 24 hours. Now, with the D50, we made it saline dextrose infusions to be incorporated into the other maintenance fluids. Like for every 8 hours in each Ringer's lactate that goes on the patient, some 30 ml of D50 would be put on as they rehydrate the patient in the maintenance fluids. And we were to initiate ORS to this patient as soon as the vomiting reduced and he could start feeding. And educating the attendants and counseling them about the disease, its prevention, and how they could really avoid to also to be infected, since this is a very highly infectious. And since this cholera is really highly contagious, we isolate the concerns about how we avoid, even as health workers. I think I forgot to put that we really used our PPEs because we had to protect ourselves, and to inform the administration, since really this is a notifiable disease, such that they could see how to connect with the other district health team to see how to take care of the situation. Next slide. And that was our follow-up. And on the very day, our patient really improved after resuscitation, and actually our NG tube was removed because the patient gained consciousness. And that very day, the patient spent a fair night. And on day 2, our patient was still weak, still having several episodes of watery diarrhea. He was still vomiting. However, his vitals had really improved, and he was saturating well on oxygen that very day. And our plan was to do intermittent oxygen therapy, and we had to maintain him on the maintenance fluids and continuation of monitoring. On day 3, our patient had improved. He was saturating well on oxygen. We weaned him off oxygen. The vomiting had reduced, and even the stool had really started becoming semi-solid. And since the vomiting had reduced, we encouraged our patient to continue taking ORS to encourage rehydration. Also, we had to remove our catheter because at least our patient would really move out to do so, or would tell the attendants that he wants to urinate. And on day 4, our patient was really doing well. However, he was still weak and had a few episodes of semi-solid stool and just a few episodes of vomiting. We did not really change the management so much, apart from encouraging oral fluids. However, we did not stop our IV fluids to avoid any other episodes of dehydration. And next slide, please. On day 5, our patient was much better. The vomiting had stopped. The stool had solidified, and he really had no major complaints. However, we kept him around such that we could monitor him more, and he had to finish his IV antibiotics for 5 days. On day 6, he was really switched off IV antibiotics and put on oral antibiotics. He was stable, and we plan to discharge him on day 7. And on discharge, of course, we had to emphasize things like personal hygiene, to boil the water and food properly. And we followed up, we really got other more cases which also turned positive for cholera, and a committee was formed at the hospital to really try and look into the matter and to see how they could handle the issue of the cholera outbreak. Next slide, please. Thank you.
Thank you, Dr. Zelda. That was a good presentation. So welcome questions. You can raise up your hand, you can write in the chat. Shall be able to get back to you. Thank you. 5 minutes for questions, please. Questions? Those who have questions, please. Dr. Zelda, there's a question. Did you do stool culture?
We did stool culture, however, I've not put the results and let me see. We did stool culture for the patients. And +3 vibrio cholerae was isolated, which was resistant to erythromycin, resistant to trimethoprim,
From excess.
also resistant to nalidixic acid, but was sensitive to ciprofloxacin and tetracycline. So we did the stool culture.
Thank you. One participant is asking, what is the reason for LFTs, for doing LFTs and RFTs?
Okay, I can respond to that.
It's okay.
Yeah, the reason for doing the LFT, RFT, this is the person who was losing a lot of water through the diarrhea. So was at the risk of going to a severe electrolyte imbalance, and the person also ended up into acute kidney injury. So it was very important to do the renal function test. And again, the LFT is very important because cholera is not the only one, the only disease that can cause diarrhea. There are others like Cholera, Salmonella, which can lead to losing a lot of protein in the GI. They are so-called protein losing enteropathies. So we'd also need to look at the albumin. So possibly that's the reason of the RFT. And again, we need to know the type of diarrhea, if it was not cholera, because we need to know whether the diarrhea is secretory or osmotic. And you do that by calculating the adenine gap, which is only possible with RFTs. That's the feedback I can give you.
Thank you. The next question. One of the participants wants to know the results of the hematocrit on the CBC. CBC is not available. I think this can go to the lab person. Number of participants would want to know, they're asking, do we only diagnose cholera on RDT, or so they need some explanation on that?
Thank you, Martha and the team. We are going to bring it laboratory investigation, but for that participant, the gold standard for confirmation of Vibrio cholerae is culture or PCR, which is a molecular technique. Yes.
Okay, thank you. Thank you. The next person. So I think, but for now, some of these questions will be answered in the chat. We are going to call in the next presenter. That is Dr. Jimmy, is going to present for us the emergency management. Dr. Jimmy, you're welcome.
Thank you. Good afternoon once again. My name is Jimmy, for those who have joined in a bit late, and I'm emergency medicine resident at Makerere University. I'm in my second year, and I'm so happy and delighted to be sharing with us on the topic of diarrheal diseases. And basically, I'm going to be handling the emergency resuscitation and evaluation of a patient with diarrheal diseases. Of course, with much bias towards cholera, and a bit of typhoid. So our case of the day has been on cholera, and that's going to form the basis of our talk today. Cholera or diarrheal disease, WHO defines diarrhea as passage of more than 3 episodes of loose or liquid stool in 24 hours. And that could go for even a period of 14 days if we are calling it acute. And then if it persists for up to 29 days, we call that persistent diarrhea. And if it persists for up to more than a month, we call that chronic diarrhea. So that should not interrupt. Yeah, so that is as per the WHO definition of diarrhea. I'm going to try as much as possible to keep this presentation simple and more clinically oriented because the goal is to improve practice in this presentation. Yeah, so like patients will present at different levels and with different severity. So it's important to tailor your approach, patient approach towards the patient that you have right in front of you. So even as we give the talk, it's important for you to tailor your clinical approach to the patient that is presenting right in front of you. So they can present at different stages. Some could present with mild disease, and that means that maybe the diarrhea has just started and they haven't yet really had any complications result of this. Others will come with moderate disease, and some will come when the disease is quite severe, and maybe they're already actually having complications of the diarrhea that they're having. Like the case that we have been presented today, already that patient actually had complications as a result of the diarrhea that he acquired. The person was asking about the importance of the RIFTs in this patient. We actually, if you looked at the result, this patient had the deranged RIFTs result. That means that the patient actually already gone into acute kidney injury. And it's quite important. It's one of those investigations we want to do if you're going to be able to manage this patient comprehensively. So diarrheal diseases are caused by different microorganisms. Some are bacterial, some are viral, but we also have non-infectious diarrheal diseases. But what we are going to interest ourselves in today is going to be the bit of it. And the infectious causes are further subdivided into the non-invasive and the invasive infections that someone could get. Among the non-invasive, we know for rotavirus, which was quite prevalent and was actually one of the killer diseases in the children under 5 especially. And that's why rota vaccine was introduced in order to try to reduce mortality as a result of the rotaviral diarrheal diseases that these children were getting. And then we have in the viral, quite often, I know that almost all of us have had an episode of actually diarrhea. For those who travel a lot and you buy maybe chicken along the way as you're moving, and you get food poisoning, maybe because of E. coli, you could get food poisoning also as a result of either Clostridium or something. Any of those, you could actually end up acquiring them from food that has not been well handled along the way as you move. So can be caused by Clostridium. You can also have Vibrio cholerae, which is actually the one that we're interested in today. And then you can also be caused by protozoa, for example, Gardia, quite common. We've had cases of entamoeba, which is quite common in our setting. Then the invasive as Clostridium difficile, which is also common. E. coli as well, still we have the entero-invasive form, and then enterohemorrhagic form of the E. coli can also cause us diarrhea that could be significant. We are not so much talking about the others because they are they are usually acute and self-limiting within like 48 hours, and they do not tend to cause us complications. But for cholera, if it's not well managed, you could actually end up with complications arising, and that could potentially be fatal for your patients. So what are some of the presentations that the patients are going to be coming up with? Of course, like the topic is diarrheal diseases, they're going to come with complaints of diarrhea. And then diarrhea usually accompanied with also nausea and vomiting, because the whole GI lumen has been irritated. So they are also going to be vomiting, they're going to be diureting. And because of that, diarrhea coupled with the vomiting, they in most cases are going to present with dehydration, which dehydration could be mild, moderate, or severe, depending on the timing when they actually come to the facility. Some are going to come complaining of muscle aches. Others are going to be complaining of palpitation because of the dehydration, and the heart has to work really hard to get blood into the peripheries in order to maintain perfusion to the vital organs. And then also low blood pressure, like for example, the case in point that has been presented, this patient was not only hypotense, but actually I would say the patient was in shock, was already having symptoms of signs of shock. And then persistent vomiting still is going to worsen our hydration status. So how do we approach this patient when they have just presented to us? One is to be sure that we know of some of the causative agents that could cause us diarrhea. So your immediate evaluation is going to be quite key in how you're going to handle this patient and be helpful to them as a clinician who is attending to them. And also a quick evaluation of some complications that they could be presenting with is going to help be able to curb down and do not and be able to curb down and prevent some of the complications that could come. Like Dr. Zelda said, they have to wear and don well as they're handling the patient, put on protective gears, because most of them tend to be infectious, and you have to protect not only yourself but also protect the team that you're working with, and not only also the team, you also have to protect other patients. So, for example, if you have a high index of suspicion that the patient could be having cholera, you'd want to isolate that patient and don't keep them on the same ward with the rest of other patients that could end up contaminating either their feeds or even acquiring the infection in the ward. So you would likely like to isolate such patients and manage them in a different setting where there's going to be limited chance of them contaminating either feeds that other patients are eating. And then because of the diarrhea and vomiting, they might also actually end up with electrolyte imbalance. And one of those that could come is hypokalemia, and then also hyponatremia that could cause ECG changes. You might not have yet gotten your lab investigation, but if you are adequately monitoring the patient, you could have your suspicion of certain electrolyte abnormalities that you could be able to actually predict on your ECG tracing. And then pulse oximetry is going to be quite key, because hypoxia will worsen the situation. Remember that we're already having issues with perfusion because of the low, because of the hypovolemia. So you want to continue monitoring your patient and make a decision as quick whether you need to advance or escalate care for this patient. The goal standard of management, or the mainstay of management, is going to be fluid resuscitation. Because they are losing a lot of fluids via the loose motion, but also from the vomiting. So you need to really replete what they are losing. And we are going to discuss how you should go about the fluid resuscitation in a patient with diarrheal disease. Of course, also as you establishing your IV line, we would preferably encourage establishing at least 2 IV lines so that you can have opportunity to rapidly resuscitate, hopefully replete your patient. And as you're taking off the sample, as you're putting the cannula, also withdraw samples for CBC, electrolytes, lactates, and then also the culture. The sample for culture especially, I think, would be best drawn at this time when you are establishing your IV line, because that is the time when you haven't yet initiated your antibiotics, and there's a best culture sample that is going to yield more results for you. So majorly 3 goals of care is rehydration, antibiotics, and zinc sulfate. So the rehydration, I said, is our main goal of care because it's what is going to actually lead to most of the complications that these patients present with. And then antibiotics also to try to reduce the bacterial load in the patient. So early administration of antibiotics is going to be key. And then zinc also has been shown to be very beneficial in diarrheal diseases. One is that it reduces on the secretions or the GI secretions through inhibiting the intercellular molecules and also the calcium channels and nitric oxide channels that that contribute most in the secretory of the diarrhea. And then also identifying any other complication that the patient could be having and managing it promptly. For our patient, we see that the patient came already with a low GCS, and our care in emergency medicine is we want to identify what is going to be life-threatening and be able to deal with them early before it actually could become difficult to manage. So we usually have the way we approach patients, we deal with the airway, breathing, circulation, disability. So the ABCD. One of my faculty say ABCD approach will never let you go wrong in a patient, because for as long as the patient is breathing, then that patient is going to give you time to intervene. For as long as the volume is adequate, then you have more time to intervene. So your ABCD approach will never let you go wrong when you're approaching your patient. So if, for example, this patient came with a GCS that is as low as 5, you will want to think about even maybe intubating this patient. But especially for these patients who are losing a lot of volume, you want to replete the volume before you think about intubating them, because the drugs that, most of the drugs that we use for intubation is going to further lower your BP. So you want to first resuscitate them before you think about maybe mechanically intubating them. That is if you're in a setting that is able to handle such level of care. Understand that it's important for us to timely intervene so we do not escalate to that point of requiring intubation. So some of oxygen therapy as well is going to be quite key. I know that already because of the volume, there's already challenges with perfusion. So you want to increase oxygen delivery to the lungs so that you can maximize how much is carried to perfuse the rest of the organs that need to be protected in that case. And if you decide to intubate them, you're going to use the rapid sequence induction in your intubation. But the good thing is that most of these patients, they're having a low level of consciousness just because of the volume. And once you replete them, they're actually going to improve and they might not need the intubation. However, I've put this slide particularly because some of them are going not to come, they're going to come not only because of the diarrhea, maybe already they had some other condition that predisposed them to actually getting diarrhea, and you might not have any chance. But you might not have any option, but rather to secure their airway because of those other additional conditions that they might present with. All right, so like I said, our mainstay management is going to be fluid resuscitation, but the fluid resuscitation depends on how sick the patient is. One of those category of patients who can easily become very dehydrated and maybe complicated the pediatric age group. So your assessment is going to be quite key in categorizing the severity of the condition they're presenting with. And all of us know signs of dehydration. This table basically is guiding us on how to chronologically assess and be able to categorize this patient to either no dehydration, moderate, some dehydration or severe dehydration. And that categorization helps us to know how much fluids and how rapidly we need to give to the patient that is in front of us. For example, if a child presents to you with diarrhea, vomiting, but They are not yet, there's not yet the signs of dehydration. You could basically just manage them using ORS, and you will be able to replete their volume and avoid them from complicating. But then if they come already with the signs of some dehydration, and then your fluid requirement is also going to go a bit high. You can still use the ORS, that is if they are able to take in orally, or at that point, if they are not able to take in orally, then you might want to opt for IV fluids. But if you decide to do ORS, then you're going to be using 80 mils of ORS per kilogram, but and that is to replace what has already been lost. But then you also have to add on fluids that is going to be for the ongoing losses. For example, if after you initiating the fluids, the patient is still diuretic, then for every episode of diarrhea, you give 10 mils per kilogram to replace that. And then for every episode of vomiting, you're going to give 2 mils per kilogram to replace what has been lost through the vomiters. Sorry. Yeah, so we continue with our fluid resuscitation. That is going to be under circulation. So if it's an adult and comes in with severe dehydration or signs of severe dehydration, which is going to be tachycardia, dry skin, dry mucous membranes, or reduced skin turgor, and then some might actually even come with already altered mentation. You want to target. You want to also give fluids at 50 to 100 mils per hour. That is, if you. Sometimes we are not given a chance to even weigh the patient. If you're able to weigh, then you can give at 20 mils per kilogram. But if you're not able to weigh, then your goal of therapy should be giving at least between 50 to 100 mils per hour as you run your fluids. And that's why it's going to be important for you to have at least 2 IV lines, because rapid fluid repletion is of essence in managing this patient and stabilizing them. But as you do that, you also be replacing the ongoing losses, like I said. Sometimes as clinicians, we tend to treat numbers. As we are managing, we are looking at the BP, we are looking at the pulse, but those can be guiding, but they can also be very misleading, because sometimes you don't know the baseline, where you're starting from. For example, if someone was hypertensive and they are maintaining a certain baseline, and for your aim is just to keep them at a BP of maybe greater than 65, and someone has been maintaining a mark of greater than 85, you miss the point. So as you rehydrate them, look at their urine output. Urine output is going to be one of those that is going to be very guiding in your fluid therapy. So if there's improvement in urine output, then you know that actually you are giving adequate volume. For example, like this case that has been presented today, came in with reduced level of consciousness with a GCS of 11. If after 1 hour of your fluid repletion, the GCS significantly improves, then you know that you're actually giving what is adequate for that patient. So do not only pay attention to numbers, because sometimes you're going to treat numbers and not the patient. Treat the patient rather than the numbers. And then if the patient comes with a mild to moderate dehydration, then you could actually give them a trial of ORS if they're able to take ORS. And you're giving at a volume of 75 times the body weight, you give that over 4 hours. And then if they do not yet have dehydration, then you're basically going to be replacing the ongoing losses, and you're doing that with ORS, which could be, I don't know, so we have ORS. And basically what we need to do is to teach them on how to reconstitute this ORS in an hygienic way, in that they do not again end up contaminating it. And we usually encourage that the one that has already been reconstituted should not be kept for more than 24 hours, because if it's kept for more than 24 hours, chances are that they are again going to be contaminated, and they will be the source of further infection in your patients. As we are discharging them, we could actually make homemade ORS using salt, sugar, and a liter of boiled cool water. And then one of the complications that could come as a result of the diarrhea and vomiting is electrolyte imbalance. the commonest being hyponatremia and then hypokalemia. But sometimes they could actually also be having hypernatremia. So, and the hyponatremia in particular can actually also be the reason why they are having a low GCS, that if you it, you might actually also not see improvement as fast as you would desire. So that's very voluminous diarrhea. There has been a fluid that that was specifically reconstituted, that was specifically made for management of cholera patients. It's called cholera saline. That has a bit of more sodium and a bit of more potassium, and also a base in it. Because like if someone has had a shock for quite some time, they're also going to be acidotic because of the ongoing anaerobic respiration due to the hypovolemia. So you also need to aim at restoring their acid-base balance. So that fluid particularly also has more acetate to help to deal with that. The rest, the best fluid, if you are going to give IV, is going to be Ringer's lactate in that case, because of the large volume of fluid that they will require. Sometimes sodium chloride would actually cause us chloremic acidemia. So Ringer's lactate would be better at management. So preferably, if you think that you have given fluids and you are not seeing response, and you think that there might be need to secure their airway, especially for those with a GCS of less than 8, you'd think about actually securing the airway if you have the capacity. And then RBS is going to be quite key. So hypoglycemia in itself can also cause you a to be sure about their glycemic control as you manage them, because they are not taking in orally, and they are losing a lot through the diarrhea and also the vomiting. So there's nothing really stays in the abdomen for them to, nothing stays in the GI for them to absorb. So you want to actually actively also control their glycemic, their glucose levels. So frequently be checking the RBS so that you avoid hypoglycemia. I was happy that at least we were able to replace and actively manage that, take care of the glycemic control in this patient in particular. Antibiotics, which one do we pick? Which one can wait? So it depends on really your history, because sometimes that you're going to even maybe do your lab test, which might delay. So careful history is going to guide you on what antibiotics you need to choose for your patients. Most of these conditions, you can actually be able to predict them if you carefully took the history of the patient. So if a patient is presenting with severe disease and you think they're already in sepsis, which could actually also be one of the complications of these diarrheal diseases, you might want to pick something that is broad spectrum so that you can give a wide coverage as you wait for your results for culture. Or even if you do not have RDT, we are lucky that at least at that point when this patient came, we had the cholera RDT and we're able to do so that it's we know exactly what we're dealing with. But sometimes you can be in a setting where you don't even have those RDTs available and you are working on suspicion. So in the event that you're working on suspicion, you need to pick something that is broad spectrum, which can cover a wide range. So you know that you're going to have a chance at it, because you want to reduce the bacterial load is one of those goals in management of a patient with septic. And then cefepime, which is not, I know it's not quite available to us. But if you are suspecting Clostridium difficile, then you also want to add on vancomycin in your regimen that you're giving your patient. Yeah, the blue thing still guides us on what choice of antibiotics you're going to be choosing. And then, of course, with cholera, like someone said, it's an infectious disease and it's a disease of public interest. Usually when there's an outbreak, you're going to be having very high volume of patients. So you must also have your disposition plan. What is your plan of disposition for the patients that you're going to be receiving? So that's part of emergency care. Where are these patients going to be taken to? Do you have a holding ward that maybe you have created for those that are very those that have been stabilized? so that you can create room for those that might be coming in. So you must also design your disposition plan, even as you're managing, especially an outbreak, if it does happen. So the beauty is that most of these patients, once they are fluid repleted, in most cases, you're actually going to be discharging them back home after certain days. But there are those that might develop complications, and you want to come up with a plan on how their care is going to continue. So your goal of care has to be well written and well planned. And some people opt for also some anti-motility drugs like loperamide, bismuth. They are good, act very fast, but sometimes they can also be a bit discomforting for the patient, because in most cases they are going to cause you again severe constipation. So I do not rush for them so much. Then your follow-up plan, remember this is an infectious disease. You're going to be discharging this patient back home. You must have taught them. You must have told them about how to prevent them from actually spreading the infection within the community. And also they should become advocates for good sanitation, clean water, ensuring that the water is boiled before it is used in the homes. Then also nutrition is going to be quite key. And if it's in a child who is still breastfeeding, we encourage that they continue the breastfeeding adequately. Then we also have, some of them are actually diseases that could be prevented by vaccination. Like cholera, there's cholera vaccine as well that can be given. Yeah, in that case to prevent. Thank you. That was the talk that I'd prepared. Welcome questions.
Thank you, Dr. Jimmy. Thank you, Dr. Jimmy, for that good presentation. So we shall welcome a few questions before we go to the next presenter. And if you think you put your question in the chat and it was not answered, please raise up your hands and we get back to you. We request Dr. Davis to read for us some questions for experts to answer, those that were not answered.
Can I ask my question pretty quick? Good afternoon.
Good afternoon to you. Please ask.
This is Jackson Gutagwa. My concern is about, thank you, doctor, for the presentation. My question is about the use of antimotylics. Some clinicians or consultants do not advise the use of antimotylics. They do believe that if, considering the different types of causes of diarrheas, it wouldn't be good to close it out. So they think it's better that we do due diligence in the management, but do not just stop it from going out. Please, some guidance on that. Thank you.
Yes, Jimmy. Please.
All right, thank you. I think you basically repeated what I said. I do not encourage so much prescribing anti-motility drugs because it actually limits your ability to adequately manage the condition the patient is presenting with. So yeah, like you said, I really wouldn't encourage. They are there, especially maybe for sometimes if someone is maybe already they had a flight that had been booked and they have to travel, they have just gotten diarrhea and it's not of public, it's not a disease of public concern, and they really have to travel maybe in such cases. So they are not the first drugs that I'm going to be going for in managing a patient with diarrhea. I only, maybe if it's a must, but can be avoided, should not be our first choice.
Thank you, Dr. Jimmy.
Yeah, thank you very much for the question. In addition, it is not good to give those anti-motility drugs because it is a defensive mechanism of shedding off the excessive bacterial load, toxins, and all that. So if it's inhibited, then we may end up having a patient going into septic shock or septicemia, bacteremia. So to initiate them, one has to know the exact cause the definitive diagnosis of what's causing the diarrhea.
Thank you.
Thank you, Dr. Kankwasa. Ahimsiwe Johnson, unmute and ask your question, please.
Thank you, Doctor, for the presentation. My question is, how do you approach a patient with acute decompensated heart failure with severe dehydration?
All right. So that's why I said that even as you're giving your fluids, of course, we are aiming at rapid fluid repletion, but then you also have to tailor your management to the patient that is in front of you. So in such cases, it will be quite key for you to keep evaluating the fluid tolerance in that patient. That's what we call fluid tolerance. Like the fluid that you're giving, in such a patient, I would encourage giving boluses rather than continuous infusion. So you give a bolus, maybe of between 250 to 500. You reassess. You are reassessing for tolerance and also fluid responsiveness in such a patient.
Thank you. Dr. Jimmy, yes, please ask a question.
In the management, about about does it also apply to the pediatric patients or about pediatric patients and on the weight?
So for the pediatric age group, we already have very clear guideline on managing dehydration. And they are quite easy at least to weigh. Their weight is monitored more often compared to an adult. Sometimes I've said that in the event that you're not able to establish someone's weight, that's when you maybe want to think about what option do I have? What option is available to me in such case? But I would encourage us actually using the weight. It is more guiding and more clinically oriented.
Thank you, Dr. Jimmy. So we are going to hold on questions by now. We are calling in the next presenter. Please, those who have questions, put them in the chat. We shall be answering them. I'm going to call in the next presenter, that is Mr. Chelengat, to talk about laboratory investigations briefly.
Thank you, Martha. Thank you, team. My name is Chelengat, the medical laboratory technologist. I'm looking at investigation. Dr. Jimmy has already presented most of these investigations, and we categorize them as supportive and confirmation diagnostics. Now, before we go there, we can just look at the path flow of how we handle these situations. The first stage, you shall receive a completed request form from the clinician, and this is very paramount in data completeness. So in the lab, you must receive this patient's service of agreement, and it should be completely filled and correctly filled with the patient's demographics. The challenge we normally get during outbreaks is that there's a lot of tension and most of this information is missed. You realize you missed the age, you realize you missed the district or the village where this patient is. Yet, for interventions, for public health interventions to contain this epidemic, we need to have completed data. And let me go to the second page. The rest of the things we shall play as we go through. Now, when you receive this request, you have to have prepared yourself for an outbreak. You must have prepared yourself for an outbreak. You must have all the supplies in place, and you must have trained your team on how you are going to coordinate the clinicians and the lab. And these supplies I've listed here are generally for all the enteric pathogens. And normally we are going to tailor at enteric pathogens of public health importance in Uganda. and mostly these are Vibrio cholerae, Salmonella, Shigella. Others will come in, like the public health important aspect where we shall have to do water sampling. In case of food poisoning, we have to take off the samples to different levels. Now, you can see the materials there, the logistics. We have full boxes, the C-blocks, cryo boxes, the PPEs are important, antiseptics, among others. Also, what is important is you can see the blood culture bottles. And these are, the blue top is aerobic bottle. And then we have the orange, which is the second, which is anaerobic bottle. And we have the pediatric bottle. Okay. Now, these blood cultures are normally done for other enteric pathogens like Salmonella and Shigella, in case they have disseminated into the bloodstream. Okay. And for cholera, you can take off as well a rectal swab in case the patient is unable to get access to some. Now, if you are unable to do culture, I've already told you that we have supportive tests and we have confirmation tests for these pathogens. If you are unable to do culture at regional referral or at district level, please pack your samples well, fill the case investigation form well, in this case, the microbiology form. I just consulted the CPHL team and they said they only have the cholera lab investigation form. For other enteric pathogens, you can use the microbiology form. Use triple packaging and communicate with the hub courier and send the samples to CPHL. If you are able to do culture like our regional referral, please make sure that you have the necessary logistics. You must have prepared well. You have your culture medias, and you have the necessary transport medias for the samples as well. Now, for other pathogens, which normally cause food poisoning, like doctor said before, the invasive hemorrhagic E. coli, the Clostridiums, the Bacillus cereus, Listeria. We also have other pathogens like the parasites. He mentioned them, the Giardias. If this is an HIV patient and it's in the area, it's also important to do modified sedation to rule out the oocysts. And there are also fungi which cause food poisoning, which normally like the alpha toxins from spiders and others. Now, under the diagnostic methods, we shall have culture, and we shall do culture for specific if we are looking at Vibrio cholerae. During our outbreak, we had crystal Vibrio cholerae RRDT of our one stream. It was a screening test for Vibrio cholerae. After screening, we went ahead and cultured our sample in alkaline water. We enriched, later subcultured and confirmed the isolate presumptively. At our regional referral level, we are not supposed to declare this isolate or declare the outbreak. We refer the isolate to CPHL for confirmation. We presumptively identified it and send the isolate to CPHL for confirmation. For other pathogens, like Salmonella, Shigella, depending on the presentation of the patient, if the doctor has seen that the organism has disseminated in the blood, he can request for both cultures and stool cultures. Okay, and for blood cultures, we monitor them every 24 hours. We provide them with the gram reaction report And also we give them a culture report after 24 hours, whether there is growth or no growth. Microscopy is done for the stool samples. Okay, rule out parasites, as I've already mentioned them. And the molecular tests are done at CPHL to do genomic sequencing for these isolates. Interestingly, during this outbreak, we realized that cholera has already developed resistance to some of these commonly used antibiotics. We got resistance to ampicillin. We got also resistance to thimerosal and methotrexate, which was really alarming, because if you look at this is an outbreak, it's not always happening, and it's already registering this resistance. It means you have to go ahead and do other things. Now, if you are dealing with the food poisoning, please pick the samples, and mostly it's advised that you pick them in the cans where they are and submit. If there are queries of litigation, this should be sent to the government analytical lab, rule out other chemical poisonings maybe. And if you need more information, you can contact the relevant authorities, especially the district health team and the ministry. Also, what is important in this is the public intervention, the public health intervention. During our period of cholera, the ministry also came in and we did water sampling to find out where is this pathogen. And samples were referred to the National Quality Water Reference Lab in Tebe for confirmation, but results were negative. Also, what is important to note, I've just said, do not confirm or declare outbreaks at regional level. Thank you. My acknowledgements goes to Minister of Health, the EMS, and the Kayunga Regional Referral. Thank you.
Thank you, Chilengat, for that presentation and edifying us. Yes, Dr. Nakalema.
We didn't find any voting in progress. We didn't find any the strain that we had, that the one that we had posted out.
Yes.
Which antibiotic was
Yes.
sensitive, which the strain was sensitive to.
The strain was sensitive to ciprofloxacin, chloralfenicol, and tetracycline. Yes.
Thank you. We can have 2 questions before we switch to the next presenter. We want to thank Dr. Anthony for answering our questions on the chat. Please, those who cannot raise their hands, they can put their questions in the chat. We have Dr. Davis and Dr. Anthony answering those questions in the chat. They are doing a very good job. We applaud them for that. Since you do not have any hand risen up, we can switch to the next presenter. We are going to call upon Dr. Nakalema, our expert, to take on her presentation. Thank you.
Yes, good afternoon to every one of us. Thank you for joining this eco session. And our focus has been on the diarrheal diseases, but mainly we should be focusing mainly on the I'm called Nakalema Irene. I'm a physician, and I work here. I'm going to be very fast. I'm sure the first presenters have done a very good job. And I think they have so much expertise in the area because the answer, some of the questions they've been answering they have so much knowledge on the subject. I'll just add, so all of us are experts here. It's not, I'm not the top expert. Every one of us is. Thank you so much for the work that has already been done. So this slide was just highlighting to tell us that diarrhea, mainly we look at the change in the texture of the stool, and not really the many times, not so many times, not that so many motions the patient is doing. So as long as someone is presenting with altered change in the texture of their stool, that will already be categorized as diarrhea. It's a passage of the loose, liquid, or watery stool. Maybe this is, where is the point? Yeah, that's right. Yeah. Okay. So you may add on the either 3 or more loose or watery stool motions, but please, we need to emphasize that there's an altered change in the texture, in the texture of the stool. Either it's loose, watery, liquid, or watery stool. The burden is quite big, and diarrhea diseases in children, they account for about 1 to 4 deaths in children under the age of 3. These have been due to diarrhea. The global estimate, it's as high as 3 billion annual episodes of diarrhea have been reported by the WHO, and 3 million deaths in children younger than 5 years, mostly among the malnourished infants. So not everyone is susceptible, but you find the factors that cause susceptibility is when our infants are malnourished. Yeah. Then for Salmonella typhi, the enteric fever, it accounts for about 14.3 million people being affected. But this has been declining with the sanitation and providing of soft water, and then vaccinations. This has been declining with time, and we are now, was a decline of about 44.6% of the annual cases by this year, 1990. And then the annual incidence rate is about 394.3 per 100,000. This in the Southern Asia. You will see that the areas that are affected are usually those people who are in very crowded areas, those that don't have safe water, areas of low socioeconomic status. So that is the Southern Asia, Africa. Those are the main people that usually get these enteric fever and other diarrheal diseases like cholera. Africa, the incidence is estimated to be about, this is for typhoid fever, about 720 cases per 100,000 per year. I didn't get the statistics because for cholera, usually because of poor surveillance, there's not so much that is recorded about the statistics. But still on epidemiology, the regions that are usually affected are those that have the areas, the developing countries. And those are the countries where we have whose housing is usually overcrowded, and areas, regions where water and there's poor sanitation and no safe water. Also, we have to note that whenever there is a conflict or a natural disaster following collapse of the water, the sanitation and the health systems, or is one of the hazards that is anticipated is outbreaks of these these diarrheal diseases like cholera. And so the country is supposed to put measures so that they are prepared. In any case, we get a disaster where we have collapse in the infrastructures, water, sanitation, healthcare systems. One of the anticipated hazards is usually such diarrheal diseases. These are the causing agents. They are bacterial, where we have the E. coli, and it produces what we call the heat labile and the heat stable enterotoxins. So there's a enteropathic one. Okay, let me be fast, yeah? All right, so this is E. coli, and usually then we have the Vibrio cholerae, which is one of the two we are going to discuss in details. Also, it acts via the enterotoxins. Shigella, then we have the Campylobacter. I think most of my colleagues have mentioned, but also viruses, especially in children. That's why these days we're having vaccination in the children against the rotavirus. And then also parasites, like the Gardial, labia, and also we have cryptosporidium in our immunocompromised patients. So for typhoid, usually it presents with fever. So this is an assessment. When the patient presents to you, usually you need to look at their history and then examination and then do the tests so that you can diagnose typhoid. For typhoid, usually they present with fever, they present with abdominal symptoms, diarrhea, constipation, and then unspecific symptoms, which are really general because of there will be weakness, there will be anorexia, there will be dizziness, and sometimes they present with what we call the rose-colored spots, which appears on the trunk. And for some, they may present with neuropsychiatric manifestations, and also some few on examination, there will be hepatomegaly or splenomegaly. These are complications. Now you need to know that the cholera, the typhoid, it can be spread hematogenously. And as long as we have hematogenous spread, that's when we anticipate all this to be happening. We have the hepatomegaly coming in, the splenomegaly, and from the foci, which is in the GI, it's then spread hematogenously. And if it's not treated, patients will present with the GI bleeding, and then intestinal perforation, and sometimes they can also present with encephalopathy. My colleague has already discussed this, but the gold standard for diagnosing typhoid, we have to use what? We have to use blood cultures. The very common one used, the WIDO, is based on detection of this agglutination or antibodies to there's an agglutination that happens to these antigens, the O and the H. But this is very unreliable. It will give you very, very many false positives and very false negatives. And I see many patients, many clinicians really depend on these to treat, but ideally you're supposed to do a culture. and blood culture, but also if you can, you do the bone marrow, but that is quite invasive. And then also the stool culture can be positive only in the earliest phases. So there are newer serology assays, which I had expected Mr. Chelenga to take us about, apart from the wide that we can use.
The IgG, IgM, which are still serology. They are quite impressive, but still there are antigen antibody reactions. And if the patient is a walking patient and the IgG is positive, so you have to go back to your immunology and look at the exposure. So it may not really mean an active infection as part of it.
You see, we have a lot of error. Many people are diagnosed as typhoid, but really it's really erroneously. And many times they're just asymptomatic, but these titers are high. So maybe they've had an exposure, then so you really need to do a blood culture, which to be the confirmation. Because I've seen people getting antibiotics and they have to repeat doses and again, and they're really being re-diagnosed and over the zealousness in diagnosing typhoid. So cholera, it usually presents after the incubation period of 18 hours to 5 days. And patients will usually present with the watery, what we call the rice watery stools, and also sometimes with vomiting. They rarely present with fever, but sometimes they may, if there is a co-infection, like maybe with a Clostridium, another bacteria. That's when they will really present with fevers. I think those who were in the outbreak realized that most of our patients were febrile. They didn't have fevers. But the main presentation is that rice watery stool. And really what happens is the toxins, what is active for someone who's having cholera, it's the toxin. It acts at the membrane, at the small intestines, at the mucosa, and then it causes reduced influx of the sodium. That is from the intestinal, small intestine lumen. It reduces the influx of the sodium into there's a pump. Where the toxin binds, and then prevents influx of of sodium. So sodium will be much concentrated within the lumen, and so usually water follows solute. So we shall have all water not being reabsorbed, and that's what causes the watery stool, and sometimes with vomiting. So in later stages, because they have lost a lot of water, they may present with lethargy, the rapid radial pulse, loss of the skin turgor, then diminished urine output, low blood pressure, rapid breathing, and then the second eyes. And if the rehydration is not, if they're not hydrated fast, they'll go into hypovolemic shock. And in fact, by 12 hours, if you haven't really started on the antibiotics, you haven't rehydrated these patients, you will lose these patients. That's why we had cases in the community who we didn't get a chance to resuscitate because there was a delayed detection of it, and then also they didn't get a chance to be hydrated. And so the complications, obviously, the loss of the fluid, they will present with electrolyte imbalance. Then they usually have hypokalemia, hyponatremia, and then the acidosis that may set in. And then my colleague, I think, mentioned something about the acidosis, how it comes about. And then because they're not feeding well, they may present with hypoglycemia, and then rarely, but sometimes because if the hypoglycemia is not corrected, the seizures may set in. And then because of the reduced renal organ perfusion, we have end organ damage. So that's why the rehydration should really be prioritized, and you should really do it aggressively if there's no contraindication, as my colleague already mentioned. And if we have reduced organ perfusion, we have end organ damage. So patients will usually present with acute renal failure, stroke, and then may get miscarriages for those that. For diagnosis for cholera, we use the clinical. It's a clinical. You have to use the clinical presentation, but also there's cultures for the stool. Is it the standard? Is it the stool or stool?
Stool.
Okay. Okay.
If he is unable to get the stool, you can also
Rectal swab. All right.
And then the aggressive hydration. Really, you need to be aggressive with your hydration. When you don't hydrate the patient and then maintain the hydration, you're going to go into all these other worsening presentations, the organ damage. Patient will get reduced level of consciousness, renal failure, and then bulimic shock because of the circulation, which is collapsed. Then adequate and timely rehydration is very important because it has been noted that it reduces the case fatality rates by rehydration salts recommended by the WHO contains glucose as a source of the carbohydrates. I think that's what you mentioned, that we have a specific one for cholera, because I told one of the complications is the hypoglycemia. They're anorexic and they're not feeding. That's why we encourage such a fluid which has the oral rehydration, so that doesn't only have the salts but also has the glucose. Then antiemetics usually have no role. They say they have a sedative effect, which may hinder someone from taking in enough orally, because we usually also encourage them to do increased oral fluid intake and then also eat, so they don't go into hypoglycemia. And then azithromycin and ciprofloxacin are commonly used. That's why I was asking Mr. Chalanget about which antibiotic for the strain we had. Because you said it was Cipro. So Cipro. They were resistant. No, imagine. Maybe this study was done in a population that was outside use. The antibiotics really have to be determined, have to be chosen or determined as per your antimicrobial sensitivity profile for the hospital or the area where the strain has where the outbreak has happened. Preventive strategies, we have to do hand washing, and then we do we get environmental sanitation, making sure they have safe water, they have latrines, and then also elimination of those who already have the disease. That is elimination of the cholera, Vibrio cholerae in the reservoirs, the people who already have the condition. So then also breaking the chain of transmission. There's that chain where you can break the chain of transmission at any point. And if you can break it at the point where the sanitation from where it goes, that's why it's going to get into the food. It's a waterborne. Cholera and typhoid are all water foodborne diseases. So that's why we need to do the hand washing, then safe water, and then the environment. Make sure they have latrines, and then they can wash their hands when they have to, like before eating. This I've already discussed. Yes, there's a role of the vaccines and those who have already, if someone has already been vaccinated, they won't get the severe form of presentation, and death may be prevented. We have the typhoid vaccine, which they took. There's one where they on alternative days, and it's oral. And then the patient who may vaccination. And those who have to take the vaccines 1 week before they enter into have the hygiene. So I mean, this government or governance level where they need to have preparedness in case there's an outbreak. At least we have the emergency medical teams and that can really come in to issue the necessary treatments and the necessary preventive precautions, so that we can, this is not on the level of the clinician, but the level of the government. Sorry, by 2030, it was supposed to be 2030, so it was a typing error.
Thank you, Dr. Irene, for the elaborate presentation. We thank you for that elaborative presentation. We shall have 3 questions. Dr. Anthony, I don't know if you can hear me. If there is any question in the chat, please unmute and talk to us. Dr. Anthony?
Yes, hello. Are you getting me?
Yes, please.
Yeah, I can see some question. I think 1 or 2. Okay, there is one that is, this is from Newton. Thanking Dr. Nakalema for the presentation, but is saying that in areas where we don't have ORS as recommended by WHO, how can we give those fluids? Yeah, that is the first question I'm seeing. Then the other one, which we have not responded to, someone was also asking how can you administer fluid in a patient with diarrhea and has partial IO? Yeah, those are the 2 questions I see here. So I don't know whether Dr. Nakalema will respond to that one.
Yes, okay. Now for the first question, you can use the Ringer's lactate. Ringer's lactate has the potassium that we need for these patients. And then you can also give regular boluses, but it's better to dilute the D50%. You know, it is very corrosive, but you can put it within your Ringer's lactate. You can do like maybe 10% solution where you get 400 mils of the Ringer's lactate and then the 100 mils of the D50%. That solution, and you do it maybe every 8 hours in between the aggressive hydration with the Ringers alone. So you have an additive of the 50%. You can't fail to make our own solution. We can always add the glucose because Ringers has the potassium, and that's what we are interested in, which normal saline doesn't have.
Thank you, Dr. Irene. Dr. Jimmy?
Yeah, I think someone asked a question, an interesting question, that in area where we do not have ORS, what do we use? I think we have always labored to actually teach people now to make home-based ORS. So you can actually make your ORS from home using half teaspoon of salt and then 6 teaspoons of sugar using boiled cool water. And you will have your ORS for the next 24 hours. And you just think we are just encouraged to keep it well and avoid contaminating it for the 24 hours.
Thank you, Dr. Jimmy. Dr. Davis, is there any question for us?
There's here screening criteria for typhoid in facilities, rough level facilities. For sure, it's not good to think about typhoid before you do blood culture, because most of the time people with typhoid present with high-grade fever. Secondly, you can collect the specimen and send it to the National Microbiology Reference Laboratory for culture and sensitivity. Meanwhile, initiate antibiotics. Once you get results, then you can get the right path to take. Otherwise, the kits which are so much on the market have not been validated. Most of the labs don't do laboratory, don't do batch to batch or lot to lot testing. And really, it is quite challenging. So the best is, if you think the person has typhoid, take off the blood specimens, send it to the National Microbiology Reference Laboratory, start antibiotics. Once you get feedback from the laboratory, then you can decide which way to go. Stool culture specimens are not good because they are chronic carriers who have salmonella in the hepatobiliary systems, and they continuously shed them in the stools. So stool culture is not the best, not the definitive diagnosis for salmonella, also for typhoid. Thank you very much.
Thank you, Davis.
Just to add on Dr. Davis' point, what is also important is that when a patient is presenting with high-grade fevers, you must rule out other febrile diseases like malaria. Okay, and then before you take off your sample for culture, please do not initiate the antibiotic first. First take off the samples. because we have found this as a very recurring issue. The sample is taken off after antibiotic initiation, and you cannot see anything. There will be negative.
Thank you. Yes, Dr. Zelda.
My question is the experts. In the guidelines of cholera treatment, it was showing that the ensicycline is a first line treatment in adults, but it was not adult in their presentation. And then I saw in those guidelines that zinc was actually indicated in adults. Why? I think these are not conditions.
Yes, Dr. Nakalema.
Really, you need to, the guidelines of Uganda, they mentioned zinc as well in the dose.
There's actually a zinc was not indicated in the guidelines.
Yes.
And then your society,
The
milligrams starts is the first phase of treatment.
No, for cholera, you need to do early detection, first of all, to suspect it, and then start antibiotic early. But the antibiotics resolve as per the strains. You know, this cholera has, I think, about 200 strains, and there are only 2 which produce those enterotoxins that cause the cholera. But also the sensitivity to antibiotics for those strains has been evolving. Maybe, yes, I've seen that some researchers that mentioned they tried the doxycycline and it worked. Yes, but for now, the recent studies really point to azithromycin or cipro. But now the good thing, we know our sensitivity, that's the antimicrobial sensitivity profile for cholera in our area. And it is sensitive to tetracycline, chlorphenicol, those all drug antibiotics, but they are working for ours. So you need to know for that particular strain of Babirye cholera. Then the other question was what? Zinc. Now, in all the guidelines I've seen for cholera, you have to start on the antibiotics early, and then hydrate. Hydrate, because we don't want to stop the diarrhea, because we want the toxin to Davis mentioned something about it. Maybe you can show it.
Thank you, Dr. Nakalema. I'm requesting those who still have questions, please put them in the chat. We are time bad. We are calling in the next presenter for nursing care patients.
Thank you, Madam Modulator. My co-presenters, called Babirye Teddy, a critical care nurse and a tutor. Good evening once again. I'm going to take you through the nursing care management of a cholera patient. So before we go ahead, let us get familiar with some 2 to 3 sentences here. By nursing care plan is a roadmap written tool in bracket for a patient or family and community, and in necessarily following the nursing process. So this is a tool. A nursing process is a 5-part system. Rational decision-making method, focusing on identifying and treating responses of individual or a group. So it has 5 parameters, and this includes assessment, diagnosis, planning, outcome, and intervention, implementation, and evaluation. Continue. So with the case presented, we did our nursing assessment, whereby we did subjective assessment of the patient relating on the case which Dr. Atyera presented, whereby our patient had profuse diarrhea our greater than 15 episodes a day. Also, our patient was vomiting every attempt to feed. Our patient had general body weaknesses for 2 days, non-productive cough for 1 day, reduced level of consciousness. Those were our subjective assessment as nurses. And then we went on for our objective assessment, whereby our that patient presented in the case had mild distress. The SpO2 was 89 to 90. Patient had sunken eyes with a very slow skin pinch called extremities. The BP was 90/55, had thread pulse. RBS was 4.1 millimole per liter, and patient was semi-conscious. So from our subjective and objective, that is where we got our nursing concerns, whereby the patient was semi-conscious, these are nursing concerns which are going to help us to come out with a nursing diagnosis and management. Our patient was conscious, mild distress with SpO2 less than 90. RBS was 4.1 millimole per liter, cold extremities with BP 90/55, pulse of 110 beats per minute, thread pulse, profuse diarrhea, greater than 15 episodes a day. Patient had 8 episodes of vomiting at every attempt to feed. So from our nursing concerns, that's where we are going to develop to draw our nursing care management, and using our subjective and objective assessment. Our first assessment. This patient had mild distress and non-productive cough for 1 day, and the patient was semi-conscious. So we came out with our diagnosis being impaired gaseous exchange related to decreased saturating blood volume, secondary to fluid as evidenced by SpO2 of 89, and which being low. We went on. First, we plan what we are going. We plan before we give. Like when you plan for a patient, what will you earn at the end? So this is the planning. So we thought that our patient will have this SpO2 above 90% throughout the hospitalization. So what we did cross monitoring, and whatever we do, we have a reason why we are doing it. This was timely intervention. So we elevated the head of the bed for our patient, which allowed this patient to increase lung expansion. We put a patient in the recovery position. Excuse me, please have a second. We put the patient in a recovery position. Yes, we put our patient in a recovery position. The reason was to maintain the airway pattern and reduce on the risk for aspiration. And we gave 3 liters of oxygen therapy, nasal prong, as prescribed. This was to increase on the rate of gaseous exchange. Then our assessment. So our patient was out of danger. When we intervened, the patient had a normal SpO2 of 95 to 98 throughout hospitalization. So our next assessment was next. The next. Our next assessment was BP 90 of 55, pulse being 110 beats per minute. Patient had thready pulse, hold extremities, sunken eyes with a very slow skin pinch. So our nursing diagnosis was deficient fluid volume related to profuse diarrhea, which was above 15 episodes a day, and vomiting, whereby it was evidenced by thready pulse, cold extremities, and sunken eyes. So we planned for our patient. So we wanted this patient to achieve normal volume status, which will be evidenced by warm extremities, normal capillary fill of less than 2 seconds. Normal pulse will be achieved and the BP for our patient will be increased. So what did we do for this patient? We administered, remember, whatever we do, we have a reason why we do it. So we administered IV fluids as prescribed. This was to establish the lost volume. Remember, patient was vomiting and had diarrhea. With normal saline, lingers, and dextrose in ratio of 1:1 and 1. So we administered antiemetics. For example, metoclopramide, 10 milligram TDS. This was to reduce fluid loss by vomiting. Remember, patient was vomiting. We also administered antibiotics as prescribed by the doctor. That was ciprofloxacin, 100 milligram BD. This was to eliminate or to kill the causative organism, microorganism. We also did the catheterization. This helped us to monitor the urine output and input. So after 2 hours, we evaluated our patient at volume in 2 hours, yes, which was evidenced by warm extremities. The capillary fill was less than 2, and also the pulse was 80 beats per minute, plus the BP had also increased. We also did another assessment as far as nursing diagnosis is concerned, which was called the extremities and weak pulse. So our nursing diagnosis was hypothermia related to reduced circulating fluid volume as evidenced by cold extremities. So our outcome plan was our patient to have normal peripheral temperature of 35.5 and 37.5 within 1 hour of the intervention. So what we did, we added extra coverings with blankets. This was, the rationale was to reduce on the heat loss by radiation. We also administered warm IV fluids as prescribed. This was to maintain the saturating volume warm. So after 2 hours, we came in to intervene, whereby our patient had warm extremities and was okay. So we also did another assessment, which was profuse diarrhea, 15 episodes a day, and vomiting every 8 episodes, whereby this patient was at risk for electrolytes imbalance related to excessive fluid loss per GIT. So what is our plan of care? This patient was to have a normal electro value as per lab results throughout hospitalization. So what we did, we continued monitoring this patient's serum electrolytes, and the reason was timely, early and timely. We also administered IV fluids per clinical and evidence guidelines. This was to help us recover the lost electrolytes. After we intervened our patient had normal electrolytes values and in normal ranges throughout hospitalization. Still, we assessed semi-consciousness. Our patient, remember, during the case presentation was semi-conscious and had RBS of 4.1 millimole per liter. So whereby this patient was at risk of unstable blood glucose level, which would be related to inability to self-feed due to semi-conscious. Remember, the patient was semi-conscious, was not able to feed himself. So anytime this patient would go into hypotension, hypoglycemia, sorry. So what is our plan of care? To maintain random glucose levels within the normal ranges throughout the patient's hospitalization. So what do we do? And whatever we do, we have a rationale. So we monitored the glucose levels every 6 hours. It was timely intervention. And also for timely intervention, we also administered dextrose 50%, 30 mL as prescribed. This and also established NG tube and prompt feeding on the balanced diet. This was to support the body with glucose for metabolism. So after we intervened our patient, whereby our patient had normal blood glucose levels throughout hospitalization. Next. So we also formed other possible diagnosis, whereby deficient knowledge. Remember, these people had no knowledge about the disease, or they had no information how cholera would be prevented, or how it is transmitted. And also we had another possible diagnosis as decreased cardiac output. Remember, the patient was dehydrated and we were giving IV fluids. So we had another possible diagnosis, which is active intolerance. The patient was semi-conscious, could not do anything for himself. Risk for aspiration, semi-conscious, and remember the patient was vomiting. That was very easier for him to aspirate. Point to note as nurses and others. Infection prevention is fundamental in the care of the patient for the safety of community and the healthcare workers. And also it needs the following: person protective equipment, gloves, aprons. You have to isolate that patient. You have to do health education of families and communities.
Thank you.
So that's all. Back to down.
Thank you, Sister Teddy, for that presentation. And we thank you for the participants for being patient. We are 5 minutes late, but we are about to close. So I'll request for a few questions, like 3 to 4 questions. Then we close. Davis, do you have any question for us in the chat?
All the questions have been responded to.
Yes, Anthony. Dr. Anthony, do we have any questions for us that have not been answered?
Okay, yeah, I see one. Someone was asking about, I don't know whether it was responded to, but someone was asking about approach to a patient with severe dehydration and acute decompensated heart failure. I think that's what he meant.
Yeah, it was answered.
It was answered, yeah.
Meanwhile, the post-test is there. As we answer questions, the post-test is uploaded So please answer in 3 minutes. Yes, Dr. Anthony, we're saying something?
Yeah, someone also asked about exudative, let's think secretory diarrhea, and then differentiating secretory diarrhea and others for learning purposes. I actually shared the link, which you could actually follow. In that literature there, in that article, you should be able to find the different types of diarrhea, secretory diarrhea, and then exudative, and then motility-associated diarrhea, plus others here, osmotic diarrhea. So that's the link that I posted there. But in short, secretory diarrhea, in this case, in a patient, cholera, which is our topic today, causes actually secretory diarrhea. And that comes out as a result of the cholera toxin, which affects the cyclic AMP and causes rapid secretion of fluids into the lumen, intestinal lumen. But because of time, we'll read about it. Yeah, that's what I wanted to mention. Thank you.
Thank you, Dr. Anthony. Jackson, can you please unmute and ask your question quickly? Jackson?
Thank you very much. My concern is to the nurse and the rest of the team. We do all agree that cholera is a public health problem. So was there any concerns from the team in regard to the public? And what interventions could have been done to involve the community and community awareness about this? Thank you.
Thank you, Jackson. The concerns were there, Dr. Nakalema talked about it. The concerns were there, the community was notified, the public team was notified, and investigations were done, and the follow-up for these patients and the community where they come from. And a lot of intervention was done, and the Ministry of Health was notified. Actually, we worked hand in hand with the team from the Ministry of Health to help this village that was affected by cholera. It happened that most of these patients that we received at that time, they were coming from a same locality. So the Ministry of Health was informed, and they were on the ground, were able to intervene. Thank you. I don't see any other hand reason. Dr. Kayunga, yes, can ask you a question?
Thank you for the presentation. Since we are here for same year about cholera and typhoid, usually our people down there at especially low level facilities, we have a lot of patients, and by the time they present regional referrals, they have already developed complications. So as the junior officer here, I may be in such a low setting where I can hardly access blood cultures as one of the recommendations for diagnosis of maybe typhoid. So recently I've been, as you have been informed, they phased out the widow test, which was one of the screening tests. So they adopted, I remember they had adopted the typhoid IgG. I know that strip comes IgM, and I think these rapid tests can easily be accessed even at low center levels. So here my concern is, I don't know, at times blood cultures take long for us to have what? Results. And you are facing a patient who is clinically unstable, and you may not wait until when you have those results ready. So for me, who is at the low center, where I cannot access blood culture, but I can maybe access the rapid tests, I need some guidance so that maybe if I can have that immediate, maybe preliminary diagnosis made, maybe as I take off samples for blood culture and the patient is what? Safe. Because what I've picked from here, the gold standard is the blood culture. So they are phasing out the IgG, IgM. So I need this to be addressed so that I can pick a leaf if I've been requesting for IgG, I also got it. Thank you very much.
Thank you.
Thank you very much, Dr. Kayanja, for the question. However, all the work we do, clinical diagnostic, we follow protocols. And you know, in a laboratory, they are in form of what? Screening or testing algorithms. And these algorithms are developed by experts. So who sit and do and decide on what to do. So there are many of those kits that in the market, everywhere, most pharmacies, wherever, but they have not been incorporated in a testing system. So if you think the patient has typhoid, use your clinical acumen, take off specimens, initiate your antibiotics, blood cultures, results cannot take more than 24 hours. If the patient has typhoid, then results, you can get preliminary results from the testing lab where the specimen was referred. Otherwise, those kits, other DTs, they are not on any screening algorithm. Possibly, I think it should have a question to the laboratory department and the ministry to come up with a testing algorithm for typhoid. Thank you.
Thank you, Dr. Davis. Yes, Dr. Jimmy.
Thank you, Davis. I think that's really it's important. Take time to actually take history of the patients and also examine the patients. We are too quick to rush for investigation. We are too quick to run for things that are without our reach, and yet our clinical assessment and our history taking are quite key. In us initiating actually some of the cases of suspicion for what infectious agent you might be dealing with, and you can actually start your treatment based on your clinical suspicion. And then, but like the lab technician told us, it's important that as you are beginning your treatment, you have also taken off a sample so that you have at least a sample that's going to give us, that's going to be good for culturing in that instance. So do not only be thinking about the investigations, think about what am I dealing with in this patient that is presenting in front of me. Thank you.
Thank you, Dr. Jimmy. Yes, Chelingas, quickly.
Still on the same, because this question has kept recurring. You realize that typhoid is general. A very misdiagnosed infection. And what is happening? People are doing window in clinics and treating these patients. IgG, IgM, if you look at the knowledge, if it is having IgG, that means it is a post-exposure. So what are you? IgM, IgG. If it is having both, because that can have both. So it will tell you that it may have a recurrent infection and active infection. Yeah? Now, that is not enough. That means that this patient is already he has already developed the immunity. Actually, if you could do a window and look at the titers, if you don't have a titer more than 300 for 160, please don't push that patient. And the challenge is we have the problem with titers. People don't do titers correctly. That's where they see the problem is investigation. Okay. That's why we have the ministry decided and struck a window because of that misuse of window. People don't do titers. And if you do a titer, you get 1/8 titer value. It is not enough. You are supposed to leave that patient for another 1 week and retest, you see. So window is not a test that you would use to decide that that you're going to test your patient. You're going to pick your patient unless otherwise. That's why Dr. Jimmy really guided that if you have thoroughly done your history, vitals, examine your patient well, we don't avoid you from treating this patient for pathogens. Because after all, we just need you to take us a sample at the point of suspicion. Okay, because your suspicion index is high for typhoid, take off the sample. Now, if you are in a low facility, the country already has regional referrals being strengthened to do bacteriology cultures. I'm aware of that. I know most of these labs, CPI is rotating, regional referral, Mbala regional referral, Ginger, up to West Nile, Arua and Yunga, they do these cultures. So within 24 hours, you must have a preliminary report for a blood culture. So there is no reason to say you are going to continue with the IgM or with the preparation.
Thank you, Chelingat. Yes, Dr. Nakalema, quickly, 1 minute.
Yes, I've seen very many people moving around with positive with results of titers and maybe the IgG, IgM, and patients are symptomatic. And patient is very bothered because the doctor said you have typhoid, and this has been on recurrent. After they take the antibiotics, they repeat the tests, and they're still there. So really, for such a patient, these are symptomatic, and they're coming with maybe high titers that are high. Mr. Chelanget has said, and I emphasize it, repeat the titers after like 2 weeks. Then you titrate, you see if they're trending upwards or they're trending downwards. But also for such a patient, do the cultures before you subject someone to recurrent antibiotics. We have the Russian use of antibiotics, and that is causing a big problem in our area of resistance to the drugs. So do a culture for such a patient. Don't just subject them to repeat antibiotics.
Thank you, Dr. Nakalema. I think we are coming to a close of our session. I think the post-test is done. Yeah, I want to thank our participants for being with us in our 60th session. And we shall have another one 2 weeks after today. And want to thank the panelists, our experts, for the good work that you have done. It was a good presentation, and all the answers, I believe, have been answered in the chat because we had 2 doctors answering there. And I was viewing there, they have done a very tremendous work. I want to appreciate everyone. I want to appreciate our IT team for the good work that has been done. I thank our sponsors for these sessions, Ministry of Health, Seed Global, really a managed emergency department. Thank you. I hand over to the expert from Seed Global to take over.
Thank you so much, Hannah, and thank you so much everyone who has attended today's session. This was the 60th session, so we appreciate those that have been with us from session 1 now. Hannah has communicated, we are going to have a next session in 2 weeks. And let us take the time to appreciate Team Kayunga for hosting this session. I think the team here, we can clap for ourselves. Thank you so much, all of you. This is the end of the session. Enjoy your weekend and see you in 2 weeks. If you have any questions, please reach out to any of the email addresses that send you the invites. Thank you and bye-bye.
Maybe you need to continue mobilizing the Kayunga community about the eco sessions and the Seed Global. Maybe you tell us the Kayunga, now that you're in Kayunga, mobilize us more. Tell us about the eco sessions and.
Yes, so Team Kayunga, I think all of us now that we've attended this session, which will be ambassadors for the eco sessions organized by the Ministry of Health, Global Health. So with continuous engagement, we shall have more sessions within the region, and then also try to learn from what is here and implement it in other places. Thank you all, and